say a friend or him out yet, and many doctor Tania or being ye, a friend Dr. Van Leuwen, or the Onwakasane introduction, professional one, or Ebetuja, and a share more. Yet to change some communia, name comma, if I'm man, saying a war, any only kaya home. Tibomodia, you assume myself. Now, call the Chinese as well, brewing to me, better to brofum. Ye, we are for the sake of Betty Foy. A big yancy will never want to talk for the amount. And Sabia also brought for no a guy, and I say, we move, Urias. Yo, it's a more Jenny live. Medas so I join with Miss Roma, if you know the Hayakoswana Shane tea, na info maba. Enti mmojuche na shase ni minda nishi na gori makuwa ya kunsani ya kamata mwiwa na fira wangaba tu ture ya. Yo, so we have Dr. Van Leuwen. Let me singularly thank him for the honor. I mean to be here to have a one-on-one interview with her. Thank you.
You're welcome. It's a pleasure.
Yeah. Right. I want you to speak a little tree for my people to know that at least you can. Yeah. So when I say to sing, you say and to say yeah. To a country in India. You were born on Monday, Tuesday, Wednesday.
I'm born on Monday.
Monday. Oh my Lord! I'm also born on Monday.
Yeah, the 9th of August in 1976. So I'm 46 years old.
Wow. Beautiful. Hey, Monday. So Monday, when you are, I mean, if you happen to be a Ghanaian, Monday born is Ajwa, so you are Ajwa. We would add Ajwa to your name.
Okay, that's good. Yeah, I knew for boys' names, but for the girls, I don't know so much.
Know.
Yeah,
okay.
yeah.
I see. Well, that's nice. Right. So, professionally, please, can you tell us your background?
Yeah. Now, I'm working here as a gynecologist for more than 10 years now, but I've also got my education before. I was a gynecologist in training, and I'm actually specialized in obstetrics because this is an academic hospital. We all have our specialty, so I'm only doing obstetrics and no real gynecology anymore.
Oh,
so
okay. I see.
I only
the obstetrics is a bigger area than the gynae.
No, probably, but I think they're I was just fascinated by pregnancy and women giving birth, so that's still I chose to do that.
Yeah. And I love your service. I have experienced you, so personally you are excellent. Thank you so much. Okay. So we are looking at, first of all, we are looking at infertility because of your area.
Mm-hmm.
I want to find out. I know that. I mean, traditionally, Africans, our understanding on a lot of issues differ from your part of the world. So I want to understand what infertility means to the Dutch.
Now, I think infertility is always a thing of two people, so it's always difficult if you cannot get any children. And actually, infertility means when it's really impossible, but usually it's more like a thing that we call subfertility, that it takes a long time before you get pregnant, but you're not sure if you're ever gonna be pregnant. And then it could be either the woman who's not so fertile, or of course the man could have less good sperms or anything. So if it takes, usually if you have a regular cycle, so if you have your period every month and you don't conceive within a year, then you have a right to at least search for a cause. And there's not always a cause found, but then the man can hand in sperm to look at the sperm analysis to see if he has enough sperm and if it's moving enough. And the woman should also get extra investigations to see if she has an ovulation every month, to see if her uterine cavity is alright, that there's not a fibroid like hanging in the middle that causes an infertility problem. And we do tubal tests to see if the tubes that give the transportation from the sperm to the egg are open, because there could be different causes why you don't conceive.
Okay. All right. So first of all, it has to do with the menstrual cycle, like a woman knowing her menstrual cycle and knowing when she ovulates.
Yeah.
So that it becomes the right time. To make love.
And usually you get, we count periods from like the first day of you see blood, so the first start of the menstruation, until the next month that you have your first day. So that's the length of your cycle. So and usually it's about 28, 30 days, and the ovulation is in general it's like 14 days before your period. So it's always a bit difficult when you're in. Yeah, you never know when your next period is gonna be, but you know the length of your cycle. So if you normally have a 30-day cycle, then your best days are like day 16, counting from the first day of your period. So, but we also know that when people are really focused on getting pregnant and only like make love around ovulation, then that's less effective than that you're not so focused on it. So, but yeah, I think, and for instance, when your cycle is 28 days, then your ovulation is usually at day 14.
All right. So, is it automatic that every woman, like every lady, knows her menstrual cycle? Is it automatic? Is it taught?
Yeah, but you can count, and if your cycle is longer in general than 35 days, then you need help. Then you don't need to wait.
But are women taught, like from growing up, are they taught?
No, I don't think so. Yeah. My mom didn't tell me. Did she tell you?
No. I grew up before I.
No, so I think that's something we should educate women. That, for instance, when your cycle is very long, then you have less chance in a year to get pregnant. It doesn't say it's impossible, but if your cycle is longer than 35 days, so counting from the first day of your period to the next month, first day of your period, then you can see a doctor without waiting for a year to conceive, because then you first need to do something on the cycle to get it a bit shorter, so you get more chances a year.
Okay, but here, is it like compulsory? Do they mount pressure on women of childbearing age to get pregnant by all means? Because in Africa, it's a different ballgame altogether, because especially when you marry, people see that like within a few months into your marriage, you should get pregnant, you should have a child.
Yeah, I think getting children is also important for Dutch women, but I know I've been to Tanzania one time, and I know that when you don't get children in Africa, it's like a disaster. And I think maybe it's a little bit less here, but it's still something that a lot of couples want. So if they don't conceive, it's a very sad thing, of course.
Yes.
Yeah.
Okay. So let's see this. When we go to parts of Africa, the mortality ratio, the rate at which women die when they go to the liver is very high. It's either the woman is dying or the child. Sometimes both of them and all that. So because of that, most women, when they are pregnant, they begin to develop fear. It doesn't look like the same fear is here. I mean, I've been here, I've experienced, having 2 children here, and I think that you feel fine, you feel very okay when we come to you for the appointments and whatever that you have to check all the time, even before the time is due for labor and all. It's not like that in Africa. What are you doing special that makes it like stress-free, like not too much of a headache, not too much of a burden, not too much of some fear for every pregnant woman?
Now, I think that pregnancy is a natural thing, so I think we just need to empower women and also give them the feeling like it's a natural thing, not look at pregnancy from a kind of sickness. In fact, it's rather a healthy thing to get pregnant. And we're in a luxury position that we can, of course, check the growth of the baby. We do regular checks of blood pressure, and if something goes wrong or somebody starts bleeding, we have a lot of blood in stock. So it's a luxury position when everything is there, of course, antibiotics in case of fever or so I think I also rely on a good medical system. If I would have to work knowing that I had nothing, then it would be a more difficult situation, wouldn't it? So it's not only my experience, but also working in a setting where everything is there that makes me relaxed. So I can also probably give that feeling a bit to the ladies I'm seeing.
Okay. So here, what are the issues that a few of the women that would have to suffer that fate. I mean, to go to labor and not come back. What are some of the causes?
Now, I think causes that are still, but I think in Holland we 170,000 women give birth every year, and I think 170,000. So not so, not so many, I think, but I think only 10 die a year. So, and I think what's still a big problem is psychological illness after birth. So depression is still a big problem, and I think sometimes bleeding difficulties or blood pressure related stuff that can still lead to death, but only in very, very rare cases. And infections sometimes. You have like some streptococcal infections can be very bad as well. Yeah.
Okay. Well, whatever that it is, there will be some patients that will not comply. I mean, patients that probably may be missing their appointment, that will not come and all of that. Are there some repercussions, and what happens if patients are not attending to whatever?
Now, we're always trying to stay in touch with our patients, but sometimes they cannot come, and maybe they have transportation problems, because I work in a very rural area of Amsterdam as well, so we should not say that we don't have any problems.
Okay.
But I think when they really don't come, we start calling midwives in the area to pay home to see if they're home, or we call the house doctor to have a look. Yeah, we do. And also every woman gets a kind of visit from the consultatiebureau, how should I call that in English, but to see if everything is all right and ready for birth. And I think that's, we have a great maternity system in Holland, I think. Yeah.
Okay. Normal delivery and the CS. Is it a decision by the patient or the doctor's advice?
Now, we do get C-sections on request, but if women really fear birth, but we think that's rather difficult to. Sometimes we go along with the woman, let's be honest about that, but mostly it's a medical indication. So it could be like either breech position, the baby presenting with the buttocks first instead of the head. But it could also happen during labor when you fail to dilate or you fail to push the baby out. Then we can also decide for a C-section. Okay. So normally it's a decision of the doctor, but in Holland we're very aware that we should talk with our patients, and of course she should agree. If she says no, there's no way you can force a C-section on a woman.
I see. So when you insist and you do it, the repercussion is on you, the medical officer.
Yeah, but you cannot. The difference between a doctor and a killer is that you get permission from your patient. So there's no.
So you always work with permission, the consent of the patient before you go ahead. Yeah. But I know there are a lot of ladies, especially in Africa, I don't know about here, that prefer the CS even when they have any medical condition.
Yeah, but I think the risk of a C-section is usually not in your first C-section, but it's in the subsequent pregnancies, because if you make a scar not only in the skin but of course also in the uterus, in the womb, and in the next pregnancy there's always a risk that the placenta will go into that scar. So you see more trouble in pregnancies after C-section than only doing your first C-section. So our goal is usually to prevent the first one in order to
avoid the subsequent ones.
Yeah, and also I think in Holland, after you've had a C-section, you still have the option for vaginal birth in your next pregnancy. While in the USA, it's like they hardly do that. They say
once you do CS, you have to continue to do CS.
Yeah, but that's not true in Holland. Okay. So you still have the option.
You can do a CS and then have normal delivery.
Yeah, but it needs to be in hospital. There's no option for home birth then anymore.
Oh, I see.
But usually we say after 2, then your third will be a CS again.
I see.
Yeah.
Okay. So after the first CS, you can do normal.
Yeah.
And then after 2, you have to do CS again.
Yeah, but if a woman really insists, then even then we sometimes agree for a labor. But it also depends on the indication. Like if it was some indications are more successful in a subsequent pregnancy than others. For instance, when the baby was turned upside down, then there's a good chance that you'll have normal birth. But if you failed to dilate, maybe that's a bit. Is that not a very maybe that will happen again. But if a woman wants, we always go along with
Yeah,
trial of labor, as we call it. Yeah.
Okay. But do you think it's wise for ladies to say that they don't want their VJ to go through that, whatever?
No, I don't think it's wise, and I think
and
it's
because
very
of that, they always have to choose.
yeah, and I think it's also very strange because in all other specialisms in medicine, like if your arm is broken, you just completely depend on your doctor how he or she will fix it. And here, only in labor, women have very specific thoughts themselves. They want to. They want to
preserve their.
Yeah, but I think that's nonsense. And I think for us as a doctor, it's always a thing of seeing where the fear is. Are they afraid of pain? Well, then you can have an epidural if you want. And if it's to preserve your tightness, yeah, then I think I think we hardly have such requests. It's most when women
hardly have such requests here.
Yeah.
Okay, and when they do request, you advise them, right?
Yeah, but then they go outside of these academic hospitals to smaller hospitals because we don't have the capacity to do so many C-sections without a real medical indication.
It's okay.
Yeah.
Oh, I see. Okay, so let's look at fibroids. It looks like most women do get fibroid.
Yeah, especially women of color, they have more often fibroids than white women.
Oh, okay.
Yeah, it's a more common problem in the African
than the white.
population.
Okay.
Yeah.
Why is it?
I don't know.
Okay.
I don't know, but there are fibroids. They can be anywhere in the womb. Do you say womb or uterus? Is it uterus the better term?
Uterus. Is
the uterus. Now they can be either inside the wall, but they can also like hang in the uterine cavity or be on the outside, like. So they're all different types, and especially the ones that are in the uterine cavity, they can prevent a pregnancy because it's like having an IUD, having a contraceptive device in your uterus.
So fibroid is not an automatic infertility issue.
It's not no. If they're in the wall, it's not. And the uterine cavity has normal space, then it's not an infertility issue. No.
Okay. But the majority of the women who have fibroids, who don't even have the background knowledge, like who are not informed about fibroids, automatically assume that it affects their chances of getting pregnant.
Now, yeah, so that's why I think if women, that's how we started this conversation. I think if women have a regular menstrual cycle, so every month they get their periods, and they don't conceive within a year, then they should seek help, and then they should see if there are fibroids in the way. And it can be either a problem sometimes to get pregnant, but sometimes fibroids can also block the cervix, so you cannot have a normal labor.
Okay, so it depends on the position of the fibroid.
Exactly.
Only the position or the sizes also count.
Now, yeah, the size. I think the position is even more important than the size. Yeah.
Okay.
And sometimes women can have a uterus like they have a full-term pregnancy. It's so big of fibroids. And sometimes we have fibroids removed before they get pregnant, because sometimes when they don't get pregnant, yeah, then you try to smaller the size of the uterus before they get pregnant. Perspective, if it's really a good decision or not. But sometimes you don't have a choice. Like if it's too big, yeah, then sometimes
because there are people who look pregnant, but they are not pregnant.
Yeah, and also it's when you have a lot of fibroids, you should have your checks in hospital, because normally in pregnancy you of course feel with your hands for the growth of the baby. But yeah, if there are fibroids that already feel like you have a term pregnancy, you can only check the growth of the baby by ultrasound.
I see. It means you cannot check it by.
No, because when it's already so firm and so big, then you cannot feel the fetal parts very well.
Okay, so up until the fibroid is blocking your access to getting pregnant, is it necessary to remove it?
I think when it's really hanging inside the uterine cavity, then it should be removed before you get pregnant. And usually,
but if it is not blocking anything, is it still necessary to remove your fibroid?
No, but only when sometimes women also, because of the uterus getting bigger, then also they have a lot of menstrual problems, because it goes along with a lot of blood loss during. Okay. So sometimes that's the indication to remove them before they get pregnant, because every month their they're losing too much blood.
Okay.
And usually before we remove fibroids, we also give like hormonal therapy in order to shrink the fibroids, to get the operation to be more successful, to make them a bit smaller already.
Okay. So when you remove fibroids, is it easy to quickly get pregnant after?
Now,
It takes time?
it takes time, and it depends if you. Now, a surgeon always makes a difference if the uterine cavity has been opened when you had to remove the fibroids. Then that's an indication that you have to deliver by a C-section in the next pregnancy. But when you only remove them from the wall, or sometimes they're having, it's a still in Dutch. How do I say it?
Still?
They're sometimes they can be like on top of the womb, that you can easily cut them off.
Okay.
Then nothing is. Then the uterine cavity is still intact. Then you can have a normal delivery.
Okay. All right. I remember the last time a lady said she was pregnant, and then her gynae told her that because she has fibroids, when it's time for her to deliver at labor, they will also take the fibroids alongside the baby in a C-section. Is it okay to do
Now, we hardly remove fibroids during C-section, and that's because the uterus is really well perfused. So a lot of blood is going to the uterus during pregnancy. So if you start cutting fibroids from the uterine wall, then the chances of causing bleeding problems is so big. So you don't do that. I think only when it's really easy, when it's only like one on top of the uterus that you can easily just cut off, then you would do such a thing.
But other than that, it is not advisable.
No, and if the fibroid is like in the cervix, so near the exit, then it's always very exciting. If the baby, it's always very difficult to predict how a woman has to deliver. Usually we wait until near term to see if the baby can pass the fibroid. So it's always very difficult to predict in the beginning of pregnancy whether the fibroid will be a problem for having a normal delivery.
Okay.
So you need to wait until nearly to full term to see, because sometimes you see kind of miracle that the baby just passes the fibroid and then there's no problem anymore. And also after pregnancy, these fibroids can shrink, because then the whole bloodstream to the uterus changes after birth, and sometimes the fibroids don't get that much blood anymore, and then they shrink by themselves. And women can also experience a lot of pain in early pregnancy from fibroid pain. So sometimes we even admit them to the hospital in order to give morphine or something and that's especially in the first 20 weeks of pregnancy. They have a lot of pain sometimes.
Okay. So why do some unborn babies die immediately they are born, or sometimes die just before they are born? What causes that?
Yeah, now it depends. Here in Holland we offer prenatal testing. And I know that's also very difficult in Ghanese population, because they're sometimes more like, well, I'll accept what God is giving me, or you can tell me that my baby is having something, but I know God is going to help me. So I know that also has to do a lot with faith. So it's sometimes very difficult as a white doctor to make a good connection to the patient in order to not to lose her faith in you. Sometimes they even run away when you say something is wrong with the baby. So we do, sometimes something is wrong with the baby and then they die. So sometimes we suspect something on ultrasound, a heart disease or anything. But sometimes also during labor still babies die. Then they don't get then we think they're all right, but probably we miscalculated the heartbeat or something like that, and then they don't get enough of oxygen in the uterus, and also after birth it could be an infection or something else. There's so many ways that it could go wrong, but I think it's hopefully women don't only think about that. I hope they have a bit of faith in their pregnancy and their child.
Okay. So how long must a pregnancy hit, and then after that there's a different decision must be taken? Like how many weeks?
What do you mean? Like how
long should it get to that it should not extend? Because when it gets to that point, then there's a decision that medically it must be taken.
You mean like
Like I know that 40 weeks pregnant.
yeah.
After 40 weeks, how long is too much for
Oh yeah. Now
a woman to continue to carry it?
I think formally you can 42 weeks is the maximum length of pregnancy. But if you're 41, then you have an option in Holland to discuss whether you want to induce labor at 41 weeks already. So every woman gets the option after 41 weeks if she wants to achieve labor by inducing labor, or if she wants to wait for natural birth until 42 weeks.
So what if it goes over a year? What happens?
No, it won't go over a
won't
year.
go.
It won't
It has
go.
never happened?
No, at a certain point, the body will go into labor. No,
Okay, so but it has never happened
it
on
has
record?
never happened. No,
Oh, okay.
no.
So the maximum is 41, 42,
Yeah,
and then it will come by itself.
yeah. But strangely enough, more women deliver after 40 weeks. 70% delivers after, and only 30% before. So yeah, most.
Okay.
So from
After,
37,
before,
yeah,
or during.
from 37 weeks on, we think a baby is ripe. It's in time. Before 37 weeks, we talk about premature delivery. Yeah.
Okay. Apart from scan, is there other way to tell that the unborn is a girl or a boy? Apart from the scan, is there other?
I think you can run blood tests, but we only do that on medical indication.
Oh.
Yeah, not just to know the sex of the baby. So I think scanning in Holland is the
main.
best option. Yeah.
Okay, but you can use blood to also tell.
Yeah, formally, but we only do it if people are carriers of diseases that only affects boy or girls, not for fun.
Okay. All right. I remember a lady had a fibroid surgery operation, and then after that, the medical team said they saw a writing on the fibroid tissue. That's what they call it, right? The fibroids that they took from the womb.
Yeah.
There were some writings on it, like.
Have
you ever encountered anything
no,
like that?
No,
Like
and I've
strange-
also never heard of that
You have
before.
never, but
No.
this is in Ghana, Africa.
Yeah, I don't know. No, I don't think of that. No,
You don't.
I think fibroids are just it's like muscle tissue.
But you
That's
believe in superstitions?
I think that's superstition. Yeah.
Do you believe in superstitions?
I think some things cannot be explained by normal things. So I think it's everybody is a bit superstitious, but I try not to let that rule in my working life. Maybe more in my private life.
Okay. All right. So, what are some of the key challenges you have encountered over a decade? You have worked over a decade, right?
Yeah.
Yes, in your field.
No, I think there's still disparities also in equal health access also here in Holland. Huh? I know that the neonatal deaths are they happen more often in people who live in the Belmermeer area than in Amsterdam South, in the more wealthy area. So I think we need to address and also give our education and information to people who may not be reading or writing so well our Dutch language, or we should. I think that's really difficult. Sometimes we meet people who don't have transportation, who have to wait for some neighbor to collect his car, and in obstetrics sometimes every minute counts. So I think that's still a sad thing, I think. Yeah.
Okay. Has it gotten to a point before in your career that you have regretted choosing this profession?
No, I only think I still like it very much, and I think it's like a second marriage or something, because we work so many hours that it's more than work, let's be very honest. But I think having a normal private life next to this job is quite difficult. And my husband is a gynecologist as well,
Oh, wow.
but only in a smaller hospital.
Same field, wow.
So that's, yeah, that combination is maybe not always very ideal for our 12-year-old son. And so,
Wow.
yeah.
Do you lose yourself? Because I know that your work is very, very demanding. Like, the patients need you all the time and all of that. Do you still get time for yourself, your family? You have a family, you have a husband, you have a child.
Yeah, no, I work 90%, so I'm off on Wednesday afternoon, but most of the time I do administration then as well, because sadly enough, our work doesn't only come with the action part, but also needing to write a lot of stuff. So I don't think I get to see my family as much as I would really like, but they're used to it. Huh? They also grow with you into this situation. And sometimes I ask my son, would you rather be your mommy to have your mommy at home the whole day? And then he says no, just keep on working. So he's also used to that.
Okay, so what's your biggest motivation to?
Now, when I studied medicine, I always wanted to be like a general practitioner or maybe a pediatrician working with children. But then I did this rotation, and I'm not a very patient girl. But when I see women who present with something, then it's easier to identify with that. And I am patient for pregnant women. So somehow, that worked out well.
I can testify.
Yeah. Yeah.
Okay, I see. So what do you do for fun then, since you are all the time on the job?
Oh, now I like to go to concerts or to ballet. I like that very much, and I like cooking, and and I consider sometimes my son as a hobby too. I go to his sports and stuff.
Okay.
And then the weekend is easily filled with such things.
Are you a social media person?
No, not so much. I think that has to do with my age. I have two big stepchildren, and they sometimes teach me how to deal with social media. But I do scan social media, but I have more difficulties in posting things on it.
Oh, I see. So you have some channels already on some of the social media platforms?
Yeah, I use Instagram and Facebook and LinkedIn for professional things, but that's it.
Oh, I see. What's your account name, if you don't mind?
Oh no, I will. I don't need to. I'll leave it to you. Yeah.
Oh, okay. All right. We have had a very beautiful conversation, and once again, this is Dr. Van Leuwen, obstetrician, right?
Yeah.
Yes, at the AMC. My name is Ohima Weyeje. Before we go, probably you have a few words to put out there before we end the conversation.
Now, I think when you want to get pregnant, it's really important that you take folic acid like 2 months before you conceive. I hope every Ghanese girl also knows that, because that helps for closure of the spinal cord. And I think it's important not to eat raw meat, to really read something about how to prepare yourself best for pregnancy. And I think it's important that you come to your regular checkups. And I think you can try to have faith in your body and in having a normal birth, because I think when you have faith in yourself, then the chances that you deliver successfully is maybe bigger. So and I think people are always most welcome to come here. I really enjoy working in a hospital like this, because there are so many people from different cultures coming here. Yeah. That's what I chose specifically, of course. Yeah.
Okay. Well, I'm done with questions though, but I just remembered this. There are times you don't give pain support. So this will be my last question. There are times that you don't give pain support. So the patient would have to do everything all by themselves with their energy. Can you tell us why?
Now, I think all women have a right for pain support, but actually there are, like, you can either give morphine with an injection, or you can give morphine by an IV drip, and then a woman can press on demand what she wants. But all morphine-like things, they just take the pain away a little bit. They don't just completely take all the pain away. And I think the best pain killing is an epidural, but then you need something in your back, and for an epidural, we depend on an anesthetist. I'm not trained to do an epidural, and when there's, for instance, a trauma, then that goes, and it's night, then the anesthetist first goes to the trauma, because we don't have all personnel here at night that can just do everything. So sometimes women then just have to wait. But the only way when we don't recommend such a thing anymore is when she's almost fully dilated, because epidural pain killing also anesthetize your motor tissue, so then you're not able to push so well. So only when things go really fast and a woman is almost fully dilated, then you have more harm from the epidural than benefits. So then we would advise just to not give pain killing. But in all other cases, women have a right for pain killing, because childbirth pain is horrible. So
Okay, I have really enjoyed every bit of this conversation, and I hope one day when we invite you to Africa, Ghana, you've not been there before.
No, I've not been there before, but I would love to go to Ghana.
Good. So send a very official, special invitation and host you in Ghana, and probably to give some special seminar form of education to women. And
only when you're there.
Yeah. Yes, will happen.
Yeah.
Only if you would also honor our invitation.
Yeah.
Yes. Okay. So thank you very much. We are bringing an end to the conversation. I don't know if there's a question I didn't ask and then you have the answer. Then you give us the answer. If there is a question I didn't ask,
no, I know, but I think you spoke to a lot of things, and I would like to do everything to like bridge cultural differences or to increase faith or and also with respect to religion or faith, and that's always more difficult for us to find out than from somebody who's from Ghana and knows all about this. So over the years I come to know more about it. Also when somebody is dead, I know that they fly away because they're afraid that the dead is there.
Yes.
I know a lot, but not everything, of course.
Okay.
So, and you need experience in order to get such, to get a better feeling for it. Yeah.
Okay. Thank you so much.
You're welcome.
Thank you. That
You're welcome.
is Dr. Elizabeth Van Leuwen, right?
Yeah, it is.
Yes. Okay, so thank you for joining us. Stay on. We are not done yet. We are still live on air. My name is Ohima Oyeje.